I would now like to invite up my good friend and colleague, Dr. Brigitte Widemann, who needs no introduction. She's from the NCI, and she's an internationally renowned clinical trials person. Thank you, Brigitte.
Thank you, Ross, and thank you all for being here. I'm really excited to talk to you about the trials that we perform at the NCI. I'm a pediatric oncologist and work in developing treatments for cancers, but also for NF-related manifestations. So this is the NIH Clinical Center. It's the largest research hospital in the United States, and we call it the nation's research hospital because we want to have extramural investigators, but patients from all over have access to this place. And what is highlighted is the Clinical Research Center, and on the first floor is where we see our patients, and many of them are patients who have NF1. So I'll give a brief outline of the talk. I will talk about briefly what is a clinical trial, why are clinical trials in NF1 important, about tumor development in NF1, how do we measure tumor changes, the changes in size of the tumor, and how do plexiform neurofibromas grow? What do we know about what we call natural history of these tumors? And then I'll review the clinical trials real briefly. This will not take all that long, but I'll give a focus on our trial with the MEK inhibitor, and then briefly go over future plans. So what is a clinical trial? It is a research that involves human subjects, patients, with the aim to answer one or more medical questions. And I think really important aspects about clinical trials are that the main aim of the study has to be determined prior to the study. Is it you want to look at reduction in tumor size, at improvement in pain? These things you have to determine prior to starting the trial in order not to introduce any bias. The criteria for who can get into the study have to be clearly defined, and we know this, call this eligibility criteria. And every clinical trial should, when we have an aim, make sure that we can actually measure this aim and this outcome. And the goal ultimately is to make what we learn in a clinical trial available to everybody in the community by publishing this as a manuscript. You all know this, but while this is research, patients are never guinea pigs. And I think we don't have this anymore. In the past, sometimes this would happen, but we so much appreciate patients participating in clinical trials, because without doing this, we would not be where we are today, and all the progress that is made by patients participating in research and helping us do the clinical trials. So why do we have to perform clinical trials? Currently, for many NF1 and NF2 related tumors and also schwannomatosis, there are no effective medical treatments, and surgery, as Dr. Forner pointed out already, many times is not the optimal treatment or is not satisfactory. So the goal can be to stop tumors from growing, to shrink tumors, to cause pain relief. Many people with NF plexiform neurofibromas have pain, and also to preserve or to improve function. And there are other endpoints. In order to get a new medicine approved by the FDA for a tumor, such as a plexiform neurofibroma, just showing shrinkage of the tumor doesn't cut it. The FDA will say that's fine, but what does it do for the patient? Does it do anything better for the patient? If it causes improvement in appearance, that would count. If it causes decreased pain, improvement in function, that counts. But just the shrinkage alone is not enough for NF, at least, because most people with NF will, live a full life, and just shrinking it will not be enough. I think many of you know this already, but I wanted to really briefly go through the three phases of clinical trials. So the phase 1 is the earliest clinical trial that we do, where we don't know yet what the best dose is to give. So the goal of these are we enroll few patients at one dose level and carefully monitor for side effects of the medicine. And then the dose that we believe is able to hit the target and is well tolerated is what we take then into what we call a phase 2 clinical trial. And then in the phase 2 clinical trial, we want to get more. We want to see, is this something that has potential to help the patient? And typically in cancer studies, we look at reduction in tumor size, because that gives us a good indication. We do that in NF2. In NF, we also want to look at, do we slow down the tumor growth? Because if I have a tumor that's relentlessly growing, and I don't shrink it, but I stop it from growing, I would say this could already be a success. And then more recently, with help of the RAINS group, and we have the forum this afternoon, we have developed functional outcome measures and patient-reported outcome measures that we incorporate to, even in a phase 2 trial, see is it actually helping. And then in phase 3 trials, these are the trials that we do to get approval by the FDA, where we show that it really shows benefit to the patient by pain reduction or functional improvement. A few words to tumor development in NF1. So NF1 is a tumor suppressor gene. That means if it's active, it suppresses tumor development. People with NF1 have a mutation in the NF1 gene, and what that does is that it blocks, that it prevents blocking the RAS protein. RAS is a protein that is required for tumors to grow and multiply, and it's active in many adult cancers and also some pediatric cancers. And so when NF1 is mutated, RAS is activated, and with that, some signaling pathways that are important in the cells for tumors to grow. And one of these pathways is what we call the RAS-RAF-MAP kinase pathway. And in there, in green, you see MEK, and that's the target of the trial that I'll talk to you about today, the MEK inhibitor. But there are other pathways that are important, and potentially down the road, we have to block more than one pathway, but two pathways to get the best results. Dr. Ferner already talked about NF1, so I will actually skip through this slide, but one point to make is because every cell has an inactivation of NF1, at least on one copy that you get from mom or dad, there is the potential that, for example, if we develop a treatment for plexiform neurofibromas, if that patient has some cognitive issues or learning problems, possibly something that helps a plexiform could help other manifestations or bony manifestations. And that's something that we do in clinical trials now. Karen Walsh is actually looking in our MEK trial for plexiform neurofibromas in patients who agree at changes in cognition, so that we learn right away, could we actually get more than one good outcome in a patient who is on a clinical trial. Plexiform neurofibromas, again, Dr. Ferner talked about the one point that I want to make. I do think that most of these tumors are congenital. They may not be diagnosed at birth, but I do think most of them are present at birth. And then these tumors tend to grow over multiple years and cause problems, including the very scared and dreaded problem of malignant transformation to a cancer tumor. These are a few examples of plexiform neurofibromas. Here you see a boy with a large truncal plexiform neurofibroma. He also has a scar which comes from scoliosis surgery. Then you see a wonderful girl. She's a young woman now and going to college, who has a facial plexiform neurofibroma that impacted on her airways, so she needs a tracheostoma. Other locations of plexiform neurofibromas, and these are MRIs, is that they can involve the extremities, like here the leg, or here, in this case, the orbit, the eye socket. And these tumors can cause vision loss, sometimes at very early age. So plexiform neurofibromas occur in multiple locations and can cause multiple problems. Our goal is to ultimately develop treatments that will prevent the development or growth of plexiform neurofibromas. This is a This is a young girl with barely visible tumor, and then when she's 3-year-old, you see it's much more visible. So if we had effective treatments, maybe we could start them early and prevent the development of these tumors. One thing that I think helped greatly in understanding how these tumors grow is the development of volumetric MRI analysis. And this was done by several groups, but at the NCI we have used it very consistently. And what this means is we measure the tumor by calculating the volume, not just by doing a line measurement. And I'll show you this method here. So here you see a neck plexiform neurofibroma, and these tumors can cause problems with the airway by pushing on the airway. what Dr. Dombey at the NIH does, she puts a very rough border on each slice that contains a tumor, and then the program takes over and puts a really nice tight border on each slice. And this allows us to calculate the entire volume of the lesion and to detect small changes in tumor size. This has really made advanced how we can measure tumors, in that we're much faster in detecting progression or shrinkage compared to when we just do a one-line measurement or two-line measurement, which is what we do mostly for clinical trials in cancer patients. So we can detect in this case that a tumor has grown by almost 60% in volume at a year, as compared to 10% if you do a one-line, or 26% if you use a two-line measurement. The other thing that using this method over time has helped us to understand is how these tumors grow. And here you see 4 patients, and each yellow dot means a tumor measurement over time. And when it goes up like this, you see the tumor is growing really fast. And our observation, and this was made by clinicians before, but we could actually confirm, is that the youngest kids have the fastest growing tumors. And then as patients get older, the tumors grow less fast. And that's very important, I think, to know for clinical trials. At the NIH, we use something that I think Dr. Mautner in Germany uses, and a few other sites, that we call whole body MRI. And this takes about an hour to do, and we scan the entire body for plexiform neurofibromas. Here you see the top of the body, you see the legs, and you see the white area here is a large plexiform neurofibroma. By looking carefully at the MRIs, one thing that we noted, and I hope I can show this to you as well, is that here, for example, you have a neck plexiform neurofibroma, and in the middle of it, I don't know if you can see, there is something that looks like a plum, or maybe like a plum or an almond. Here you have another tumor in the pelvis of a patient. Is a very large diffuse area, and then you see this larger area that looks like, again, like a plum or like an apple. You can really identify this as distinct and separate. And the more MRIs we did, we noticed, okay, these are really different, and we actually did PET scans, and Dr. Ferner started using these PET scans in England, and we are using them as well. And what we noticed is that these lesions that are round or oval shaped, some of them actually light up on the PET scan, which means they're more active, their metabolism is more active, and tells us it could be different in the biology. I'm showing you this because it has implications for the treatment with the MEK inhibitors. So we analyzed the relationship of age and growth of tumors, and what you see here is is the age in years of the patients, and then the percent change in the tumor. And as you can see, the highest percentage change is in the youngest patients, and in the older patients, we do not see growth more than 20% per year. And this tells us if we have a patient where we see a lot more growth, this might not be a plexiform neurofibroma. Now, we also analyzed the growth of what we call these nodular lesions, these grapes or plums. And you can see based on the graph, the growth there is all over the place. There's really no relationship between age and the growth rate. And also, if you look carefully, we don't see these tumors in very young patients, which tells us they develop at some later age, and we're really carefully looking at this at the NIH. So we believe these nodular lesions may have a different biology. Another, I think, really interesting aspect about studying the natural history is that, and I didn't believe this in the past, but there is spontaneous reduction in tumor growth after the tumor reaches a maximum size. This is one patient, and you can see how his tumor grew faster, then it slowed down, and then after reaching a maximum volume, you can see a slow decrease in size over time. We have seen this in several patients at the NIH, and the patients are shown here. Typically, they are adolescents or young adults, and the decrease in size is slow over time. But what this tells us in summary is that tumors grow for a long period of time from childhood to reaching adulthood, and then actually slow down, and in some patients actually will decrease over time. Now, understanding the growth of these tumors has really helped us with the clinical trials. A few things that we pay close attention to One is people with NF1 cannot be on treatment for plexiforms just for a few weeks. Likely they have to be on the medicine for a long time. So we really try to identify what is the lowest dose that will have the best effect on the tumor so that we have minimal side effects. And we need to monitor the young children, especially because they will grow up, they won't have a family, so we have to be prepared to make sure that we have minimal side effects. We're also working hard on identifying what are the best outcomes in clinical trials, and we incorporate more and more pain and quality of life and function already in earlier clinical trials. Now, who can go into a clinical trial for plexiform neurofibromas? These are the eligibility criteria for most of our studies. We want to enroll patients that have a tumor that cannot be easily surgically removed, because then surgery should be the first choice. And we would like to enroll patients that either have growing tumors and with us the potential to develop problems, or patients that have clinical problems. Pain is a major issue in NF tumors. There can be airway compression, and there can be functional impairments, loss of range of motion, strength, bowel bladder dysfunction, and impaired vision. It's very important to always balance the risks and the benefits, and I can tell you until recently we really didn't have much benefit from the trials, and it was even more important, but it's very important to discuss with families what are your expectations and what is actually realistic to get to. In order to participate in a trial, patients have to have, in generally, a good condition. That means they have to be able to travel to the site. They have to have normal organ function because we look at the side effects of the medicine. They should have no other big medical problems that would allow us not to judge if the treatment has side effects. And there is a strong commitment that is actually required because patients have to come for evaluations on the study. And there's a lot that we're asking from patients who participate in trials. This is a list of clinical trials that have been done within the last 10 years. And if I go back 15 or 20 years, there were hardly any clinical trials, but now there are actually multiple. There's a lot of work going on, and I think that gives me a lot of hope that we'll make a lot of progress. I will talk today about the trials where we have some positive outcome, but start with the study that was the first big study that I conducted, and that was the only study to date that included a placebo. So a placebo is a sugar pill that doesn't contain the drug, and this trial was started 15 or more years ago when we had very little knowledge about how these tumors grow. So patients with progressive plexiforms, that means plexiform tumors that grew, were in a double-blinded, randomized fashion assigned to get treatment or the sugar pill. I didn't know it, the patient didn't know it. And they were treated with the drug or the placebo, and we monitored for progression, for tumor growth. When the tumor grew, they were crossed over to the other treatment, and it was again blinded. This really worked because the drug had very, very few side effects, so I was indeed really blinded to this. This shows you the outcome, which was somewhat disappointing, actually very disappointing in a sense that what you see here is what we call a Kaplan-Meier curve, and what this shows you is how long it takes for tumors to grow. So everybody starts off at 100%, nobody has had tumor growth, and with each patient having growth, the line goes down. And so here you see that most patients would have had tumor growth, and the important part is the lines really overlap completely, so there was no benefit from the study drug, which we would have liked to see come up here, the line, but it didn't. And then we did a number of other clinical trials, and these are all highlighted here, and we compared them to the placebo. The placebo is the red line of the first study. And what you can see, like the green line, and I maybe flip through this real quick, the green line is pegintron. This is the line here, and you can see that's the one that moves out the furthest, that has had the best success, which means it took about 2 years, 22 months for tumors to grow compared to 10.6 months on the placebo of the first study. But none of this is really, in my mind, a clear success because we want tumors to not grow for much longer time periods. Does this picture make sense? Otherwise, I'm happy to explain it more. Okay, I hope it makes sense. This shows another aspect, and maybe you can just focus on the right two columns here, where we look not only how long does it take to grow, but do we see shrinkage of tumors? And for us, shrinkage means more than 20% shrinkage. So on these studies, we only had 2 patients who were treated on pegintron who had actually more than 20% shrinkage, but no other patients experienced shrinkage in a number of clinical trials. Then there was a study conducted by Dr. Kent Robertson and Wade Clapp at Indianapolis, and I want to show this to you because that was another study that actually reported success and showed some shrinkage. Imatinib is a drug that is approved for leukemia patients and has a very good scientific rationale to be evaluated in plexiform tumors. And what you can see here is a line graph. And what you see, this is where the patients start. If the line goes up, it means tumor growth. If the line goes down, it means tumor shrinkage. So you can see Dr. Clapp's study showed some tumor shrinkage in patients. But what I want to point out is that this was mostly in patients with very small tumors that are somewhat smaller than the tumors that we see. They did not see shrinkage in any tumor that was more than 20 milliliters. I'm now coming to the phase 1 study of the MEK inhibitor, selumetinib. And there are different types of MEK inhibitors in development. Ours is called selumetinib. And what it does, it blocks just one target, and that is MEK. So many drugs block multiple targets, but this is very plain and straightforward. It blocks MEK, and with that, we hope the signaling from NF1 to RAS, RAF, and MEK. The study goal was very simple. We wanted to find out what is the highest dose that we can safely give, and we wanted to check, do we see any tumor shrinkage? The drug is given by mouth twice a day, and every 5 months, patients come and get an MRI to see if the tumors are changing. In addition, patients undergo a lot of safety evaluations. These are the dose levels that we tested, and I'll come back to that in a moment. So this is what's required on the study. On phase 1 studies, we monitor really carefully for side effects. So patients had to come for physical exams, blood tests. We check that they're taking their medicine, and they also get evaluation of their heart, of their eye, to make sure we don't have any bad side effects. So we enrolled, this study is complete at this point, we enrolled 24 patients, and they had, for the most part, pretty big tumors with a range of 1 liter. That was the average, and the range was 29 milliliters for a small tumor in the eyeball, and up to 7 liters, so very large tumors. What were the baseline problems some of the patients had? There were disfigurement, pain, decreased range of motion, but not every patient had a clinical problem. Some had just growing tumors. And here are the trial results. So the maximum tolerated dose and the dose that we took forward in the next study is 25 milligrams per meter square. We dose per body surface area in kids. This is approximately 60% of the adult dose. So adult patients with cancers get higher doses than our children. Overall, the side effects were mild and manageable. We had no severe side effects, other than 1 patient had a transient decrease in the effect of in the ability of the heart to pump that completely recovered. We had no vision abnormalities. Many patients have lightening of the hair. And importantly, all side effects when we stop the medicine have been reversible. And this shows you, and I'll try to explain this to you, this shows the response on the treatment. It's a little bit complicated, but I'll guide you through it. So this is the first dose level, the second, or dose level 1.5, and then the second. And we call this a waterfall plot. And this shows you if a tumor goes up and grows, it goes this direction. If a tumor shrinks, it goes this direction. And the red bar that you see here is the best response of the patient, and the yellow bar right next to it is the current response after multiple cycles. And what you can see is that every patient had tumor shrinkage, every single one, and a number of them, 70% to be precise, had what we call a partial response. That means more than 20% shrinkage. You also see that nobody had more than 50% shrinkage, so the best we saw was reduction by half. And then one point I want to make, when you see the stars up here, these are patients who had a dose reduction for toxicity. And if you just focus on the patient over here, This patient had an initial response but had a dose reduction for side effects, and the tumor starts growing back. That means we have to be able ideally to dose without dose reductions. So we had actually 17 of 24 patients with a partial response. We have not had disease progression to date, and patients have been on for multiple treatment cycles. The first patient enrolled in 2011. I show you a few examples of the responses, and I hope you can see those. This is a belly tumor pre-treatment, and then there's a belly tumor on treatment. It's not gone, and that's one thing that my patients understand now too. Unfortunately, we don't see them go away completely. I had a little boy just the day before yesterday in clinic, and his tumor shrunk by 26%. And I asked him, so did you know your tumor was shrinking? And he said, yes. He has an arm plexiform. He said, I have more loose skin. And then he said, I knew it was shrinking because I could fit in my jacket again with my arm. But then he said, will it ever go to 100%? And I could not say yes to this. So we have to do a lot better. But I think you can see this is an improvement. This is a neck tumor that got smaller, and this is a leg tumor that got smaller by measurements. Very importantly, I think, is that some patients had decrease in pain, in disfigurement, and improvement in function. We have a girl who had decreased range of motion who now lifts her arm all the way. Unfortunately, we did not collect this, what we call prospectively. The FDA doesn't like us to flip through the charts in hindsight and say something got better. We need to do this prospectively, and I come to that in a moment. This shows you, I think, another important aspect. This shows the patients before treatment and then when they started treatment. So many had growing tumors, and these growing tumors would then shrink subsequently, which I think is very important. This is the last slide that I have. So we are very excited that we see tumor shrinkage, and we see that actually some patients have clinical improvement, the best we can tell. We're doing 2 studies now, and one of them could potentially lead to approval, potentially. That's the pediatric study. And in the pediatric study, we do the same thing. We look at tumor shrinkage, but every patient gets pain and quality of life evaluation. And then depending on where their tumors are, they get standardized functional evaluations. For example, a patient with an airway tumor has to do a sleep study, pulmonary function tests, a walk test to look at endurance, and a questionnaire. So it's a lot that we ask patients from, but the goal is to show ourselves, will this actually improve the function of a patient? And this is what the FDA will look for approval. And then we have an adult study. This study actually is pretty much done with enrollment within a year in record time. So we're really grateful to all of the patients who participated. And then we have another study for adult patients where we do very similar things. But for the adults, we include biopsies of their dermal tumors and of their plexiform tumors because we want to see what dose is required to get a response and what are the mechanisms of resistance. I think this is coming to the end. I really want to thank all patients and families who participate in research. In the future, we want to engage you even more. Like if I build a new clinical trial, I will reach out and see what matters to you, and we'll have the patient engagement session this afternoon with Rains. This is really, really critical. We're also developing a study for dermal tumors with Dr. Korf with the selumetinib. There's many people to thank for. CTEP is the trial sponsor. AstraZeneca provides the drug. The sites, within the NCI, we have a lot of help. The referring and participating sites. And then the Children's Tumor Foundation has provided funding for the phase 1 study, and NTAP is providing funding for the phase 2 study. Thank you very much.